Yeah, I understand. Thank you very much, Dr. Jaya Prakash Reddy, President of AYFA, and for giving this opportunity to moderate this session. And I have a great pleasure to introduce our speaker of the day, Dr. Prahlada N. Is an eminent ENT and gynec surgeon. He is a very skilled surgeon and did wonderful work and the most sought after faculty for many workshops, conferences in India, not only India, but many countries around the world. And he organizes regular workshops at his place, Chitradurga. I had the opportunity to attend some of his workshops at Chitradurga, state of the art and truly international quality. Well organized programs at his place. And pleasure introducing Dr. Prahlada N. Going through his brief biodata. Dr. Prahlada N. is a graduate of Jaya Medical College, Mysore University, Davangere, Karnataka. He completed his master's degree in ENT-Head surgery from the most serious universities of India, the Postgraduate Institute of Medical Education and PGI, Chandigarh. Later, he received advanced training in advanced endoscopic surgery, ear and pelvic surgery, head surgery, reconstructive surgery, microvascular surgery, and colon surgery in various institutes abroad. He also done MBA in hospital and healthcare management from Vishakhapatnam, postgraduate certificate course in technology and innovation from Mastoid Institute of Technology. Executive Management Program, Strategic Management for IIM Lucknow, and Senior Management Course in Healthcare Management from IIM Kozhikode. And Advanced Certificate in Artificial Intelligence for Digital Health and Imaging Program, IIS Bangalore. He started and developed one of the best departments in Vishakhapatnam Hospital, a 700 bed hospital in North Kerala. And we did a pioneering work and published a book on imaging for endoscopic scanner surgery. In the year 2000, he was awarded the R.A. Cooper National Award for the original surgical technique, the Karnataka Lab for Mastoid Obliteration. It is the first and only person to get this award in the state of Karnataka. From year 2000, he started the ENT and head department at Basaveshwara Medical College in Hospital, Chitradurga, Karnataka, and working till date as a senior professor and former HOD. And he presented and published many original research articles, developed original treatment and surgical technique, and won more than 18 prestigious gold medals for his research activities. Indian Medical Association Karnataka State Branch has recognized his contribution to the medical education and have been awarded with Best Teacher Award 2022. As a resource person, he has delivered lectures, aid sessions, demonstrated various surgeons, more than 500 national and international courses and conferences. He has trained more than 120 junior ENT surgeons from India as well as abroad. He has produced many educational CDs, DVDs to teach ENT fraternity. He holds membership in many professional societies and has also served some of these societies in various capacities. He has organized many national and international academic events. He also associated with Rotary International and conducted more than 450 camps in more than 19 countries and performed free surgeries for more than 48,000 poor patients with various ear problems. And the second is in his services, the Rotary International has awarded him the most prestigious Professional Excellence Award. In August 2009, he is working as a senior visiting consultant at Brain Super Specialty Hospital, Bangalore. He is witness assistant to entry specialty from Dura to Flora. He is also a chief scientific advisor at one of the Fortune 500 companies developing innovative medical technology and products. So, he is not only ENT surgeon is a multifaceted, multi-talented, and put it in a one word, he is the best all-rounder we have seen. Not only ENT and many other fields. So I have great pleasure inviting Dr. Prahlada N to give his presentation.
Yeah. Thank you very much, sir, for that wonderful introduction. I hope I live up to that expectation. So nice of you to elaborately speak about me. Thank you so much. I'm really blessed today. Okay, I will, without wasting much time, I will start my presentation. I hope you all have my presentation right. Okay, I will also, I would like to switch off my camera so that, 1 minute, so that I have a better bandwidth to uh, speak without any this thing. Yeah, okay. I will share again. Yeah, yeah, yeah. You all have my presentation, right? Hello, Kishore sir. Am I audible?
Yes, sir. Yes, sir.
Yeah,
Yeah, yeah. Okay. Yeah, you all have my presentation also, right?
yeah. We are able to see the presentation.
Yeah, yeah. Thank you so much. Okay. This is one topic very close to my heart, very dear to my heart. Okay. So when I started this, this was considered a kind of, anathema or a crime to do. This is a kind of thing. When I first presented way back in 2000, many of the top otologists said, what you're doing is very risky. You should be very careful about it. Anyway, I had my conviction and I had my science with me. So I went ahead. Okay. But now I see that a lot of otologists in the country have accepted this as norm and have started doing this, using this technique to avoid cavity problems. Okay. So let me deal with this art and science of Mastoid Obliteration. Okay, I also consider this a kind of journey of hope, faith, and fulfillment in the field of otology. Recently, I spoke about this as a part of my oration at Solapur. I had a great time there, and same presentation with little bit changes I'm making here at this juncture. So before making the journey, I would like to thank the AOIAP, Andhra Pradesh, mainly all the office bearers, starting with Dr. Jaya Prakash Reddy and the entire team, who have been doing these events continuously, consistently, and credibly. And that takes a lot of planning, organization, and forethought. I really congratulate Dr. Jaya Prakash and the entire team. Putting up this great series of educational programs. I hope, I pray His Almighty give you a lot of strength, health, wealth, and happiness, so that you continue to do this forever. Okay, not just a few hundreds, maybe thousands. Okay, go on doing it forever. Okay, yeah, I would like to dedicate this to my alma maters where I got educated. For that is JJM Medical College, where it gave me a lot of solid basics in medical science, followed by PGH Chandigarh, which gave me a foothold in otology. Then, I had a stint of working at Al Shifa Hospital, Pentalmanna, where I started my career. And that's where I started my otology career, who supported me a lot, and followed by Basaveshwara Medical College and Hospital, where I'm working here. I need not say how much influence this gentleman, who is no more, that is Dr. Mahadevaya, kind of father of otology in India, has on Indian otology. And, he was the first person who really made me realize the possibilities in otology. Way back, I remember, I think around 96 or 97, there was a workshop, live surgical workshop in Calicut. For the first time, I saw him operating, and the mastoid bone was melting like butter in his hand. And followed by our senior colleague, Dr. Vijendra, who has been one of the leading otologists and regularly conducting a lot of teaching programs. Whenever we call, he's always there at the other end of the phone to help us and give one or two tips, this thing. And also, when it comes to understanding the depth of science, the middle ear mechanism, middle ear hearing mechanism, and all those things, uh, uh, I met this gentleman, Huttenbrick, only once in lifetime, but I went through entire his research work, all his publications. He has done wonderful work in middle ear mechanism and pathology in the middle ear mechanism in various pathologies. I encourage all the who was there here, my colleagues, to read his publications. And my friend Surendra Prabhu from Kannuru is kind of non-conventional surgeon who has a lot of innovative new ideas, and is a very good friend to talk to all the time and give a lot of photological tips. I remember him at this juncture also. And last but last least, Dr. Mario Sanna. Even I spent there just 1 week along with Jaya Prakash Reddy and many other friends as a group led by Professor Morwani, and we had wonderful time there. But what I gained there in that 1 week of time is the confidence, confidence to do any kind of surgeries. I didn't have a formal training in lateral skull base surgery before that, but after watching him doing, it was like a magic. Once I came back, we were doing all kind of lateral skull base surgeries. It was all that confidence which was lacking in us, we got in Piacenza. That was an awakening, I would say. Okay. Yeah. Coming to the hope, why we obliterate the mastoid. Let me begin with that. Okay, hope is, see, I did not start mastoid obliteration to obliterate the mastoid itself, to overcome cavity problems, that is being considered now, mainly done for, for cavity problems. See, I was working on my tympanoplasty and ossicloplasties, and I found that even though in 4 years, I started getting, in the initial period of career, started getting good results with tympanoplasty. As far as ossicloplasty, I was not getting good results at all, specifically in canal wall down cases. Okay, wherever we have done this for cholesteatoma, even though I have reconstructed the tympanic membrane and the result was not good, that is when I went after it, like, we have to get a good result in this case also. How can I do this thing? Why this? There is, even though we have done a good mastectomy, canal wall down mastectomy as per the book, as per the senior surgeons, reconstruct the middle hearing mechanism, reconstruct the tympanic membrane, still there is the hearing results are not optimal. There is something, the concept called usable hearing or serviceable hearing. Even that wasn't there in some of these patients. When I researched, then I found that our extraordinary canal has this resonance, optimal resonance for 2000 to 3000 hertz. I mean, these sounds are conducted better. But what happens when we do canal wall down mastectomy, because of the cavity, this resonance is altered. Okay, and because of that, that sound perception is not there. The whatever sound is traveling, hitting the tympanic membrane, it's not able to generate enough vibration, enough this thing there, that augmentation, sound amplification is not happening there. Okay, that's when I realized this mastoid cavity has to be closed. How can I close? Then I went and back and referred the literature, found that there already enough literature in the near, there is already enough information or articles are there in the literature by the time already. This is when in around 96, 90, 97, 98, I think. Yeah. So that's when I went after mastoid obliteration. Then I went through all the literature and found that there was not even single technique, single material which was very good for mastoid obliteration. So then I had to find, my own technique of, doing a mastoid obliteration. That is when I came up with this technique called Karnataka flap, which is nothing but post-oral, pedicled, periosteal, muscular, and fibrous tissue flap. How we do it, as usual, we go with the post-oral William Wild's incision. Then whatever skin is there, undermine the skin over the conchal cartilage as it's shown here. Okay, undermine the skin over the conchal cartilage. Then you elevate the flap, conchal perichondrial flap. This is conchal perichondrial flap. Okay, and expose the conchal cartilage while doing so. Okay, you elevate this flap elevate this conchal perichondrium like a flap, go on elevating until the extraordinary canal here. Okay, and once you reach the extraordinary canal, oh, I'm sorry, it got stopped. Okay, once you reach the extraordinary canal, you incise along the extraordinary canal, and then what you do, you make two horizontal incision, one along the linea temporalis, the other one along the tip. Now, along with this conchal perichondrium, you elevate the postoral soft tissue. This is, periosteal, periosteal soft tissue, and fibrous layer, muscular, even that whatever was vestigial muscles are there, they're left attached to there. Okay, you elevate that flap, then you, as usual, you do a good canal wall down mastectomy. See, as such, you have exposed the conchal cartilage, and from post-oral route only, you harvest the conchal cartilage in entire Simba concha region and cut them into small pieces, okay, like a palisades, okay. Then what you do, you cover the mastoid, mainly aortic region and the mastoid antrum and the tip region, senodural angle, using this cartilages pieces, okay. Then you cover these cartilage pieces with the temporalis fascia graft. You do the midlayer reconstruction with the same temporalis fascia, cover these cartilage pieces. Then what you do, this postoral pedicle flap, whatever is there, this conchal, perichondrial, periosteal flap is there, that use that flap. It kind of sunks, it kinds of gets sunken in or falls into the mastoid cavity when you replace it back. Then use that to obliterate the remaining mastoid and cover this flap with the temporalis fascia, then the skin of the extraordinary canal. Okay. Then what you do, you stabilize these flaps so that while closure, it doesn't get pulled out or anything. You put a one suture superiorly, one suture inferiorly. Then what you do, you meatoplasty, conchomeatoplasty. As such, you have taken out all the cartilage here from the conchal bole. You just have to split the skin, the conchal skin into two flaps, superior flap, inferior flap, and and stabilize them and suture them superiorly to the temporalis muscle as well as inferiorly to the over the fibrous tissue of the mastoid. Okay. Now what you have is now. Okay, 1 minute. Oh, 1 minute. Let me. Now what we have is.
And at this moment, Dr. Prahlada.
1 minute, sir. I will. Let me finish.
Yeah. Please, go ahead.
Yeah.
Go
Okay.
ahead.
Now you have a wide meatoplasty. Okay, and you fill this with ointment soaked gel foam pieces. Okay. Yeah. Yes, sir.
Yeah. Only just I wanted to know. I have seen you placing all the cartilage palisading harvested from the conchal cartilage,
Yes.
and then putting the also your soft tissue flap over it. Are you going to create a small neo-attic or neo-aditus or neo-antrum sort of thing, or you are going to totally obliterate whole of the space?
All of the space is obliterated. Complete attic, aditus, and antrum as entire mastoid bole is obliterated, sir.
Totally
Create,
obliterated.
yes, total obliteration. Now, what is left is only the mid layer. That's all.
Only the middle ear cavity, which is being ventilated through the incision tube. That's
Yes, sir. That's all.
And
Okay.
please go ahead.
So now what happened? Okay. So see, this is one of the cases where surgery has been done. 14 years post-op follow-up, I'm showing you. No complaints. There is serviceable hearing. Less than 20 decibel gap. So this is one of the patient, signature cases, one of the earliest patients. You can see that the cavity size is little increased because atrophy of the soft tissue and all. But the cartilage pieces are staying there. Okay. And you see very well reconstructed tympanic membrane. Patient is very happy. This is okay. This is one signature case where we had fantastic results. Several such patients. Okay. Yeah. Patient is very happy. Okay. This is my center. But do we have similar results in all cases? Okay. But there are some cases where, what I did, it did fail. I can't say like every case did very well, but some cases, there was recurrent cholesteatoma, the cartilage got absorbed, it got displaced, flap got atrophied. Okay. And we have few cases recurrent cholesteatoma like this. Okay. Yeah.
Particularly when it is associated with incision tubal dysfunction.
Dysfunction, exactly, sir. Perfect. Yeah. Okay.
So even after all these procedures, the retraction pocket can still happen.
Okay.
Yeah. Can still happen.
Yeah, there is one more case I'm going to show you.
Is this mastoid obliteration is going to help in any way to reduce this recurrent, like on comparison, without obliteration with obliteration, the recidivism as well as the incidence of retraction pocket on the long-term follow-up?
Yeah. This is another case, patient who did well, has no complaints, healed well. See, this is one of the earliest cases when we used to make the myotoplasty very wide. You can see, you can put your thumb inside. one of the
Yeah, it's
very
wonderful.
good
It's wonderful.
wonderful, done well. But anyway, that is nowadays it's cosmetically not acceptable to many patients. Okay, and this is the same patient. Okay, I think this is another patient. Let's see. Yeah, another patient has healed well. Everything is okay, but the flap got absorbed, and you see, everything is okay, but the cartilage pieces are in situ, no recurrent cholesteatoma, but the cavity has become little bigger, isn't it?
Yes.
Despite putting a pedicle. And see, patient is very happy. His hearing is good. He is very happy. Okay, that I think I did this surgery when he was still a small child. Huh? Okay, that is the result. Okay. Now this is the technique, Mastoid Obliteration technique, which I named after my state as Karnataka flap, and I submitted to the AOI this thing. And I got RF Cooper Award in 2000, and that put me on the national flap. Whatever I did this, and that's when suddenly everybody woke up. Okay, this is a possibility, and this is obliteration can be done. Okay, and also many did question me. Said, you can't do this. You're not sure of. Complete extent of the cholesteatoma, and so many questions were there. But let me come to that now. Now, what is the optimal treatment for cholesteatoma? You all agree with me that it is a single stage procedure which eradicates the disease, that's cholesteatoma completely, and it also eliminates the mastoid cavity. Okay, and creates a good middle ear space so that we can give a serviceable hearing, and it reconstructs the sound conducting mechanism. I think this is one we are all on same page. You all agree with me, right? So this is what is important is eliminates the mastoid cavity. It is not common factor across the world. Okay, while some surgeons do, some surgeons do not do. Okay, so what options we have? What the options we have is, one is canal wall up surgery, other one is canal wall down surgery. So the coming to the point which is you raise like recidivism, which is combined residual disease and recurrence disease. To put it in a funny way, if somebody else has done surgery, it's residual disease. If I have done surgery, it is recurrent disease. Anyway, together, together it is called.
Who is that?
Yeah. So together, it is the coin. Somebody has coined the term as recidivism. Together, okay. Now coming to the recidivism with canal wall up surgery, it is up to about 16.3%, and canal wall down surgery is 7.3%. Definitely, it is less than half with canal wall down. Okay, so the chances of recidivism are definitely high with the canal wall up surgeries. Okay, so that means canal wall down mastectomy with tympanoplasty has become gold standard for cholesteatoma. That is, I think we are all on same page. Okay, so we do very good. Yeah, good canal wall down mastectomy as shown, beautifully shown in this picture. This picture is from otological surgery atlas from the Stanford University. I once, I tried to draw the pictures. When I found these pictures, I thought there is no need to draw the pictures. Nobody can draw better than this. Okay, so we do entire canal wall down mastectomy, and you do the grafting so that you give a this thing, good middle ear conducting mechanism, and many still leave the cavity alone like this. They don't obliterate. Okay, but what are the problems of discharging mastoid cavity? There's several. One is it requires regular care. Patient has to come back at least once in a 6 months for for years ear cleaning, and this, and we know how troublesome this ear cleaning in this patients is. Some patients tolerate well, some patients do not tolerate well. They get vertigo on the examination table, then you have to wait, make them sleep, and again clean. Lot of trouble, and also intolerability to water and resultant infections. They cannot involve in any water sports after that. They cannot swim, and they cannot dive, and they cannot go below a waterfalls, and even they have to lifelong they have to keep their ear dry. And this also gives rise to vertigo, mainly due to caloric effects. Even there is little cold wind, they will get vertigo. Water enters here, they get vertigo. That's always troublesome for them. And if you want to fit a hearing aid, that is even more troublesome. Suppose, see, this is cavity, the mouth. If meatoplasty is wide and wide, it is good. If not, it is like, it's like a container, small mouthed container. Huh? Bindige, we call it, we use here village side water container where The mouth of the container is small, and the container itself is very big. The cavity is like that. So if you if you take a impression and give a this thing to patient, hearing aid to patient, fitting that is very difficult. Okay, and also because of change in this resonance behavior of the external canal, altered acoustic behavior of the external canal due to wide cavity, that also causes decreased hearing. And also the unsightly appearance of the pinna due to large magnetoplasty, which I showed you. Yeah, that also gives rise to this thing, unsightly, this thing. This all, many patients, it's not acceptable for them, but inevitability. We'll tell them this is cholesteatoma, this is the best we can do. That was the scenario earlier. Okay. Yeah. Coming to mastoid obliteration, when did it start? The Mosher, one of the earliest otologists, he introduced this concept of mastoid obliteration in 1911. Okay. He basically used a superior base flap, a picture like this, superior base flap to obliterate mainly the synodural angle and mastoid region, but that left cavity and tip area. Yeah, Dr. Kabir sir. Yeah, Dr. Kabir sir, can you mute your audio? Kabir sir, can you mute your audio? Yeah, okay. So use the superior base flap. Now there are numerous techniques. Many local flaps, free grafts are there. Local flaps either they use in isolation or in combination. Muzzle, periosteum, fascia, various things are used. Coming to the free grafts, bone chips and bone pet, this is the commonly used material among many surgeons, and this was introduced by Palva surgeon, otological surgeon of Falva flap fame. Okay, and you can collect. This is she is bone dust collector where you can collect. You put it between your suction tip and the suction machine. This in the collector, it gets collected. All the fluid goes, and the only bone chip remains here. Okay, and there are autologous and alloplastic materials are available. The autologous material considered, we can use the fascia, fat, free or dice cartilage we can use. Coming to the alloplastic material, hydroxyl palmitate has been used, bone cement has been used, titanium has been used of the recent, even silicon blocks, and now the recent thing is bioactive glass, ionomer glass is there for the last 10 years, but I don't have any experience with any of these allopathic materials. Okay, I don't have any experience, honestly. This thing. So, how does mastoid obliteration helps? What it does is, as we can see in this picture, in the coronal picture, it eliminates the mastoid entirely. Now, what is left is only the mid layer and the eustachitum connecting it. Okay, so because of this, see, for a ossiculoplasty to work, it needs a good 0.5 ml of minimum 0.5 ml of mid layer air compression pressure, a volume of the mid layer. Okay, and here when we oblitate the mastoid, it eliminates the need for gas exchange in the mastoid. Okay, it completely eliminates the need for gas exchange, and whatever exchange has to happen in the mid layer only. Okay, so that pressure on the eustachian tube also comes down. The demand for the eustachian tube also comes down. Okay, so this is how it's supposed to work, and it has been working. Okay, yeah, this is exactly what mastoid obliteration does. So in this, when we obliterate, it has to, we also have to obliterate the attic region, auditus region, and entire mastoid bowl, the synodural angle and the tip region, entire that has to get obliterated and leave only, let alone only the mid layer and mid layer. Okay, coming to the indication, when are we obliterating the mastoid? One is when there is a large mastoid cavity, we have to obliterate. When there is recurrent residual disease, you go back, do a revision mastoidectomy, and remove all the disease, and you go and obliterate. And if you suspect a poor eustachian tube function, okay, recurrent retraction of the tympanic membrane, and again you go and do it. Discharging mastoid cavity, patient is trouble, go do the revision surgery and do the mastoid obliteration. And difficult to access residual spaces. Okay, this difficult to access residual spaces means that space is there, but there is no disease. Okay, so when it is there, what happens is there may be collection, mucositis, and all those issues. And again, okay, in this case, also go ahead and do the obliteration. And high risk patients for recurrence, like cleft palate and other cases, patients who have undergone radiation, radiotherapy, or something like that. All these high risk patients where you don't expect a a normal eustachian tube, again you go and do a Mastoid obliteration. And to avoid long-term cavity care, of course, that's the main demand here. You go and do the Mastoid obliteration. And also, when you plan hearing restoration procedure like ossiculoplasty, okay, ossiculoplasty also, you go ahead do and Mastoid obliteration, because if the mastoid cavity is there, and you can only do a tympanoplasty, you cover the mid-layer, that's all, okay. And that is, mastoid is no way is going to contribute for his hearing improvement, rather it's going to worsen, because there is altered resonance in the external canal, okay. Coming to the contraindications, so if you suspect any infection or residual cholesteatoma, don't do it at all. This is one of the prerequisite, okay. You have to excise the cholesteatoma completely. If you think that you have done a inadequate surgical control of the disease, may not be cholesteatoma, even mucosal disease there, something is there which is likely to trouble, don't do it. And poor patient health who cannot tolerate your surgery, and he just cannot, he has a lot of multiple comorbidities, you just avoid that, okay. And in a immunocompromised status also, you avoid mastoid obliteration. And also, if there is insufficient volume of soft tissue or obliteration, see, this is one of the important point, because I operate in 5 to 6 foreign countries. I go to Middle East and Mass and the African countries. I find that when I go to Middle Eastern countries, I find that the volume of the soft tissue is too much in these Middle Eastern patients. All over Middle East, that's all over United Arab Emirates, Iraq, Iran, all that region, they have sufficient, very thick temporalis muscle, and all the soft tissues around the pinna. Whereas when I go to Africa, many regions, even though they are also meat eating people, rather they eat beef and all, and I expected them to have, like Middle Eastern patient, a thick temporalis muscle, fascia, and fibrous tissue, and all that soft tissue, the thing. Surprisingly, there it is very thin. Temporalis muscle in many African countries, African patients is very thin. Surprising. I know. And again, if skull base defect or CSF leak is there, first do you do a definitive closure of the skull base defect or CSF closure, then go for the mastoid obliteration, okay. And also, if there is poor compliance, poor patient follow up, you suspect patient coming from far off place, if you don't expect him to come regularly, if any issues are there, just try to avoid mastoid obliteration. We get once in a while some international patient, unless I ensure that there is some surgeon taking care of these ears in their respective countries, I usually avoid. If somebody is there, of course, I'll go ahead and do it. Okay. Now coming to the what are the problems with the flaps which we use? No, so various flaps. I'm going to tell you about that. Usually, they're not long enough to cover all the critical areas of the mastoid cavity. What are those critical areas? When you have done a good canal wall down mastectomy, first you have to cover the facial canal. Okay. Later lateral semester canal, because you don't want, while cleaning the ear or doing any manipulation, you don't want to injure the facial nerve or work on the facial canal. And also you don't want to expose the semicircular canal, lateral semester canal, for the cold water or the cold wind, so the patient has vertiginous sensation. And also synodural angle and the junction of the labyrinth, where the debris is likely to collect, okay. The epithelial debris or wax likely to collect, so you want to obliterate that region, so there should be enough sufficient tissue. So one of the problem with this flaps is there may not be sufficient tissue. Coming to the muscle tissue, may undergo atrophy with consequent loss of volume of the flap, which I demonstrated to you. I showed you where cavity has healed very well, there is obliteration is there, cartilage is there, but the flap itself has gone atrophy over course of time, okay. The size of the cavity is increased. And also adverse factors that hamper the normal healing and epithelialization. Sometimes there may be localized infection. As such, we operate in an infected ear. We do use a lot of aseptic precautions, but still there may be infection, there may be ischemia, or flap necrosis can occur. Flap can give away, and again, there is whatever you have done good obliteration has gone to the wind, then again you may have a problem. Coming to the large flaps need large incisions, it goes without saying, where some large flaps like temporoparietal facial flaps, big flap like this, based on superficial temporal artery, you can take that. But in order to take that, you have to extend your incision, postural incision of pebble, like as if like sometimes we use for cochlear implantation. Sometimes I use it for microshare reconstruction to elevate temporalis fascia flap, wide flap, big flap. You know, yeah. We all these cases need to require longer incision, and patient may not accept it. Whether they ask whether you did ear surgery or upper skull surgery, something brain surgery you did. They'll ask. Okay, so these cases are mainly reserved for case of radionecrosis where large amount of bone is necrosed. Okay, also following sometimes subtotal petrosectomy, other major surgeries we have done for some other indications, tumors, benign or malignant tumors. Also, sometimes we use this flap. Okay, that is what we use. Other challenge, continuing the challenges with the flaps is surgeon should have conversant with, you should be conversant with different types of flap. You should be aware. That is, one is blood supply. Let's have this flap and what are the flaps we can arise with, which size, what size, all that we should be concerned with. And we should choose from a wide range of surgical options. And however, there is no study showing that one flap is superior to many others. If you open the book and read, mainly, uh, I forgot that Swedish Mirkotas, Swedish surgeon Mirkotas. You go and read his books where he beautifully describes mastoid obliteration with wide range of flaps, grafts, and all that. He deals with each and every case, what works, what not. I tell you, the beginners, particularly here, there may be a lot of juniors also joined this meeting. If you want to read kind of history of different otological surgeries, how they evolved, what works, what doesn't work, it's like a meta-analysis. That book is Mirkotas. If you want to be a good otologist, of all the books, you should also read Mirkotas' book. I would strongly advise that the thing. Coming to the faith, that is prerequisites for mastoid obliteration. Okay, so what are the best? This thing prerequisites: have a thorough knowledge of temporal bone anatomy. This is very very important. You should know the facial nerve anatomy, labyrinthine anatomy, and all the dural plate, sinus plate, and complete air cell system. The SSL system, there is it is extensive usually in the temporal bone. There are some air cell system which is seen to the ear, some not seen to the ear. And also try to master this different mid-layer mucosal folds. Once you do canal wall down, what do these folds do this thing? But at least that will help you to understand the pathophysiology of cholesteatoma. Master this anatomy, know the cell tract so that you can follow. Okay, and also you must do complete excision of cholesteatoma. This is the first and foremost requisition of the mastoid obliteration surgery. Okay, complete, get a full exposure of the cholesteatoma. And some surgeons try to, okay, I will do this a limited canal wall down mastectomy, or intact ridge mastectomy and all that. So you should be sure of, if you want to use these limited techniques, you should be sure of complete excision. You'll have to use some endoscopes, other methods, in order to examine that you're not left any cholesteatoma. And you should only one, if you're 100% sure that you excise entire cholesteatoma, you go and obliterate. Otherwise, simply no. Okay, and complete eradication of the disease. See, complete eradication of the disease means I do not speak of only cholesteatoma, granulation disease, mucosal disease, whatever is there, you're trying to eradicate. And specifically, you look for disease in the sinus tympani region, that is medial to the pyramidal process, medial to the facial canal, and here sinus tympani region also. Okay, and this is endoscopic view of the mid-layer and mastoid. And here is the eustachian function and facial recess is here in the facial recess region, in the medial to the facial nerve. You also look into the sinus tympani region. Okay, you have to examine and do complete eradication. Only one pre-op evaluation, even I was hesitant in the beginning, that is getting a CT scan, HRCT temporal bone done. So I'll tell you, after having one or two bad experiences, I realized that I must have, if I'm going to do a good mastoid obliteration, I must have the CT scan. Okay. Even now also once in a while, if patient is poor, I simply don't write. But I'll tell you one thing, if your patient can afford it, you please go ahead and do a CT scan. CT scan before cholesteatoma surgery is in many ways. One is the diagnosis of cholesteatoma itself, where you find a lot of soft tissue density mass, which is non-dependent soft tissue mass, which doesn't enhance in the mainly sitting in the attic region, and where it has caused the erosion of the scutum and also expansion of the mastoid, erosion and expansion of the mastoid antrum and destruction of bony destruction. You can find that is, you can for sure you can say it's a cholesteatoma. This thing, okay. One is it will help you make a diagnosis of the cholesteatoma and assess the extent of the disease, where you can follow the disease and dissect all the disease and remove this thing. And also, if any residual cells, normal cells, innocent cells are there, you will be able to recognize. Of course, in cholesteatoma, most of the times it is sclerosed mastoid. You don't have to worry about it. But at least it gives an idea if any air cells, innocent air cells are there lurking behind, because when we obliterate, we completely disconnect them away from the outer world, isn't it? Yeah. So is there, but usually they don't create any problem. I've observed these air cells sometimes. When these such air cells are there, I've obliterated and seen. They usually don't rebel, but at least you should have an idea. Okay, you should be able to follow, and it will also help you to the CT scan. Also helps you to assess the status of the ossicles, so that what kind of ossiculoplasty you may have to do, whether you need a prosthesis, you can use a cartilage. You can use the same cartilages, same ossicles, remodel them, use it, and also that gives an indication. Okay, and also CT scan, you will be able to assess hidden areas, pathology in the hidden areas like sinus tympani, okay, all this synodural angle, tipsel area, all these areas you can assess with a CT scan. And also you can have get an idea about complications. Okay, any impending complications are there, like this erosion of the lateral semicircular canal, okay, semicircular canal, fistula. So all this you can assess. So it's a good idea to have a pre-op CT scan, HRCT temporal bone beforehand. Okay, if somebody wants to interested to get a in-depth knowledge about how to read a CT scan, not your radiologist will help. And however, if you want to assess yourself, I am doing a very good course on February 16th, that imaging of the temporal bone. If somebody interested, they can register for the course. Okay, it's a 8-hour course. I'm going to deal with normal anatomy as well as various pathologies of the temporal bone. And also you should understand the etiopathies of the cholesteatoma. It's a diverse nature. Different theories are there. Like the commonly accepted theory is obstruction, vacuum, retraction. That's the commonest accepted theory is there. And also squamous metaplasia is there. Squamous immigration is there. Immigration theory, and also basal cell hyperplasia theory is there. This is not just for for the examination sake as a PG examiner or PG student. You learn this and later forget it. No, because I believe, I consider, after doing in-depth research in cholesteatoma, that is, the cholesteatoma is a multifactorial. Having an in-depth knowledge about this, it definitely helps. And also understand the growth pattern, pathophysiology of the cholesteatoma. Okay, and we know that the commonest form of the cholesteatoma is posterior epitympanic cholesteatoma. It arises in the posterior superior region, mainly the pars placida retraction. It starts from there, and lateral to the ossicles it extends, and it goes into the adductus and then grows into the antrum. So that, you see, now there is this concept of flexible otological surgery, where you do, if there is a retraction pocket or limited cholesteatoma, you can just do a articotomy, aortic reconstruction. All these concepts is evolving. Okay, so you should know this. And posterior mesotympanic cholesteatoma, second commonest cholesteatoma, usually arises in posterior mesotympanum, and from there it ascends up medial to the ossicles and goes into the adductus and antrum. This is second type of cholesteatoma. Third cholesteatoma is anterior epitympanic cholesteatoma. Again, the retraction, instead of posterior superiorly, the pars placida retraction is anterior superiorly is there. Okay, where the remaining rest of the middle ear and mastoid may be normal, where here also you can do a limited surgery and get away. Okay, this is one of the. So understanding this growth pattern, it will give you a lot of possibilities in cholesteatoma surgeries. It doesn't have to be canal wall dome in all the cases, But anyway, here we are discussing with the mastoid obliteration, so we'll confine to the canal wall down in this presentation. Okay, so do not try to dissect all innocent air cell system. You identify the air cells, air cells on a CT scan, but you find that the cholesteatoma is not extending there on the CT, and also while operating, then don't go there. Then just don't bother. You don't have to dissect each and every cell, and it is practically not possible, impossible. There are many air cells which are not accessible at all. From eustachian tube area, there is one air cell tract which goes, anterior to the cochlea and goes to the petrous apex. You all know the approach to the petrous apex, okay? It's all around the labyrinth and cochlea, okay? They take that. All those cells, is difficult to trace them and dissect them. Don't do that, okay? But you should be able to dissect all of cholesteatoma. This is a must, okay? This is a must, okay? Yeah. And you should do a well saucerized mastoid cavity and without any ridges and recesses. This is one of the prerequisite. Do a good canaloplasty. You lower the facial ridge up to the facial canal, and you saucerize it nicely. So when you put the flap or graft or something, so there is no impediment to that. Okay, it seamlessly goes and fits into the mastoid cavity. That's what you should achieve. That's very important. Okay, and adequate meatoplasty. You can take off entire cartilage of the conchal bowl without giving any cosmetic defect to the patient. Okay, and don't be afraid of infection, pericarditis or anything. Okay, that happens when you don't use proper aseptic precautions. For me, including a incision and drainage, any surgery is a major surgery for him. Each and every case I do use proper aseptic precaution. I will never enter OT without a scrub trust, and I will never allow any of my staff to violate any of the aseptic precaution principles. It's a must. So if we, as long as we follow that, don't worry about any pericarditis, anything. You can, go ahead and excise the entire conchal bowl cartilage and use it for this will allow both the things. One is it will allow a good meatoplasty, and it will also give good material for the mastoid obliteration, conchal bowl cartilage. And you take the cartilage with perichondrium, okay? Yeah. And maximum lowering of the facial ridge to the level of the facial canal. This is also very important. You should lower the facial canal, the facial ridge up to the canal. And we all know that this is one of the main cause of recurrence of the disease, collection of lot of debris, wax, epithelium into the mastoid bowl. Patient comes back with recurrent ear problems. And earlier our teachers used to say, when you lower the facial ridge, the floor of the extraordinary canal should be at the same level as the tip of the mastoid, okay? At the floor of the mastoid cavity, okay? And tip of the mastoid is at lower level, but what happens in these cases is usually sclerotic cases, okay? And you find that they are at the same level, okay? So entire cavity, if you leave the facial ridge high, it becomes a kind of kidney shaped cavity, okay, like this, okay, kidney shaped. But if you've done a good lowering, then it should become a oval cavity. Remember, oval cavity. And also you should do adequate canaloplasty to remove the anterior canal bulge. That is also very important. You should remove the anterior canal bulge also there, so that patient has a wide extraordinary canal and no collection there. Okay. And continuing with the prerequisite of the mastoid obliteration, drilling out the mastoid tip to allow the flap to smoothly lay in the cavity. Okay, here this will achieve two objects by removing this mastoid tip here. One is you can let the sternocleidomastoid muscle and also part of the possibility of the digastric to cave in, kind of herniate into the mastoid cavity, giving a partial obliteration. And also the whatever flaps you use, that also it smoothly fits into the cavity. Okay, that also you can do this. Okay. And coming to the free graft like bone peta cartilage, whenever you use this bone cartilage, bone paste, if you used it, or the bone dust, or even the cartilage, you must cover it completely. Nothing should be exposed. If the cartilage or bone dust is exposed, that will get extruded. Okay, it will also get infected. So either you can use temporalis fascia to cover it, or periosteal or pericranial or muscular flaps to cover it properly. Okay, that is a must. Okay, so coming to the graft source, we have we as ENT surgeons are very, very lucky. Otologist mainly, very, very lucky. Whatever you graft you want, it's available to you around in and around the pinna. Okay, you want muscle, you want fascia, temporalis fascia is there. You want muscle tissues there. You can also, if you want, you can also get sternocleidomastoid flap. Okay, so muscle is there. And if you want, and muscle, this scalp region, you all know the different layers of the scalp. Okay, so there is the temporalis fascia is there, and pericranial this thing pericranium, that connective tissue is there, loose alar connective tissue is there, periosteum is there, and epicranial aponeuris is there, and outside the skin is there. So you can get skin, you can get temporalis fascia, you can get pericranium, and loose areolar tissue, that is full fascia, or false fascia. You can get all that, this thing. Okay, and temporalis fascia is so big. Temporalis fascia is there. I think the Professor Hazelblack from Hong Kong, he also described a Hong Kong flap. Okay, Hong Kong flap. Also, that is, he took entire temporalis fascia flap to obliterate the mastoid surgery. For a long time, that created a huge this thing huge noise in the otological circles. Hong Kong flap everywhere. Also, coming to the cartilage, conchal cartilage, see, this entire conchal bole cartilage is available to you without causing any cosmetic deformity. You can take it, this thing. And coming to the blood supply, have an understanding of blood supply. So we have, here we have occipital artery is there, and posterior auricular artery is there, then the superficial temporal artery is there, deep temporal artery, branch of the superficial temporal artery is there. They're all supplying all around. So you can raise pedicle flaps here, okay, without compromising the the flaps, without giving rise to flap necrosis or anything. You can do an obliteration. So pedicle flaps are always better. That's the dictum. This thing. Coming to the fulfillment, what is happening now? Okay, now I do whenever I feel that primary surgery, well planned surgery, I go for my technique, that is Karnataka flap. If not, what I do is, alternatively, I have not planned for the Karnataka flap, then I go for mastoid obliteration using Rambo flap or Muirman's flap. So what is Muirman's flap? Muirman's flap is, it is inferiorly based flap. That is inferiorly based flap over the occipital artery and posterior auricular artery. Okay, this is the postoral soft tissue artery, inferiorly placed. I raise it like a inferior base, so flap, pedicle flap. What is this? Is Muirman's flap. Okay, supposed to be a German otologist named after him. Okay, and if not, what I do is I use the Rambo flap. Rambo flap is nothing but a flap of temporalis muscle based on deep temporal artery. It is anteriorly placed here. Okay, I take this flap. Okay, this Rambo flap, and this is Rambo flap. You can take as big as you want. Okay, you can take entire temporalis muscle in the posterior of or superior of. You can take a lot of muscle. Temporalis muscle is available in this. Okay, see, when you're coming to the, see, when as such, this is inferior base flap. If you want to obliterate more of the mastoid tip region and mastoid bowl, this inferior base flap is very good. And if there is too much synodural angle region or tegment region or attic region that that you want to concentrate in the obliteration, this Rambo flap is very good. Okay, together you can do. And bone, of course, lot of bone is also available. Bone pate, you can also use, drill some bone around that, this thing, to rise this without causing any harm to the patient. You can drill little more, do little more saucerization and get more bone pate. That's always there. But when you're rising this flap, you should be very careful about the mastoid emissary vein, and this thing, emissary artery is also there. So that may cause little brisk bleeding. Anyway, as a surgeons, we shouldn't be worried about bleeding, but be ready with your electrocautery or bone wax or something to stop that bleeding. That suddenly it will cause a lot of tension if you inadvertently injure this region. Okay, with this, I'm going to show you one or two videos of mastoid obliteration, how I'm doing. So here, canal wall down being done and has been done, and also I'm doing anterior canal wall. I am drilling the anterior canal wall mainly to do the anterior canaloplasty. Okay, complete mastoid canal wall down mastectomy has been done, and I'm lowering now the facial canal. Okay, facial ridge. That entire ridge I'm removing. I'm lowering up to the facial canal, facial now. Okay, and also the tegmen region, no overhang, nothing is left. This sinus region, that is also there. Also, nothing is left, and whatever disease is there. Oh, I'm sorry. What happened to the video? Okay, so 1 minute, 1 minute. Yeah, whatever diseased skin is there, okay, you have to excise all the diseased skin and the tympanic membrane. You don't want to leave any disease behind. That too, when you're doing obliteration and burying the mastoid cavity, you don't want to bury the disease, isn't it? Then what you do, you kind of undermine the skin over the postal region, conchal region. Okay. In canaloplasty, I did before starting this drilling itself, but here I am doing it once mastectomy is done. Once you do the undermining, then whatever postural soft tissue which is left attached to the here to the pinna here over the conchal cartilage, you elevate it off. You expose the conchal cartilage. So while you do so, this entire flap is available. You keep with this as retain the attachment, inferior attachment. You go up to the inferior part here, up to the tip of the mastoid, and retain this as a flap, pedicle flap. Okay, that soft tissue. Now what you do, the conchal bone cartilage, okay, you incise the cartilage. You feel with the other finger, you feel the conchal bone, okay, and identify the margins of the conchal bone, and you make the incision and excise the conchal bone cartilage. And retain the perichondrium over the cartilage, because you always have to use cartilage with perichondrium, because cartilage doesn't get blood supply. It gets the blood supply by diffusion through the perichondrium. So retaining the perichondrium is very important, otherwise cartilage gets necrosed. Okay, and whatever ossiculoplasty you want to do using the same conchal cartilage, you can do that carving required for the same. Then what you do now, what I am doing is using electrocautery, I am doing undermining of the skin and the toward the postal region, towards the occiput here. Okay, toward the occiput here. Okay, I will expose the temporalis muscle here. Fascia has been taken. Expose the temporalis muscle. And what I'm going to do, use the electrocautery to mark your flap here. And that part was not shown. Somehow it got deleted. I'm sorry about it. And this, you raise this anteriorly base flap, and you raise it up to anteriorly up to that level that the flap is freely moving. Okay, so that it doesn't get retracted. The muscle has contractile elements. It can get contract, and it can contract and pull it outside. So now what you do is you do your midlayer reconstruction. Okay, you do the midlayer reconstruction. You undermine the temporal fascia graft anteriorly. I usually elevate it off from the annulus, the anterior canal wall skin, along with the remnant tympanic membrane. So now you have done the. I'm sorry, it got jumped. I wanted to show that last part. Okay, I've done the ossiculoplasty. Okay, then this is the arctic region. Okay, you obliterate the arctic region completely with nicely cut cartilages. Okay, and the curvature of the conchal cartilage, it usually fits in such a way that whatever curvature you required to reconstruct the midlayer, you get it from these cartilages. So once you've done that, what you do is you use the inferior base flap to obliterate the Okay, inferior base flap to obliterate the inferior half of the mastoid, that is the tip region and the remaining the mastoid bole, and this anterior base flap, that's the rambo flap or temporalis muscle, use it to obliterate the synodural angle, attic and additis region. Okay, and there is underneath that there is also a cartilage, and these two flaps. Oh, 1 minute, 1 minute. Why it is jumping to next? Why it's in hurry? Okay. Okay. And these two flaps are covered by the temporalis fascia first and then the skin. Okay. So that way, these two help the epithelialization. In early period, there may be some granulation formation over this, but subsequently it heals. You just have to scrape it up during the, post-op visit. That's all. That's the only issue you face that this thing. Okay. And see, this is now with this, I'm showing you one case. This thing. Where
Okay, go on, yes, go.
yeah, you can see this is here. Well, looks like normal extrinsic canal. Patient has the tympanic membrane is healed well, extrinsic canal is healed well, obliterated ear. Okay, and another case, same obliterated ear. Okay, uh, let me. Okay, yeah. Uh, Thank you very much. That was my presentation on mastoid obliteration. I hope I covered all the prerequisites. That is my journey. That is hope, faith, and fulfillment. Okay. I'm not going to give you the statistics at this moment because I'm still doing that statistical analysis, trying to publish that in a peer-reviewed journal. I'll tell you one thing. The results are at par with any other technique and any other results which have been there in the literature. There's not much difference because I think the middle ear and mastoid, they behave in such a way. Whatever you do, some recurrence, some recidivism will always be there that we need to accept and be ready to revise those years. Okay. So this is my center at Chitradurga. Okay, Karnataka ENT Hospital. I invite you all to visit this center sometime in your life and witness some of the work we are doing. And this is the state of the art surgical lab where we have designed 52 different courses in 52 different subspecialties of ENT. Okay, and we have put up all the equipment, audiovisual facilities and simulators so that we can train our junior colleagues so thoroughly in whatever surgical skill they want to learn. So welcome you all to visit the center sometime in your life. Thank you very much, sir, for giving me this wonderful opportunity.
Prahlada,
Yes, sir.
this is Dr. S.K. Apparao.
Yes, sir. Yes, sir. I
How are
came with your voice. I could recognize. Thank you so much. Thank you so much.
Excellent talk.
Yeah, yeah.
And you have given very good importance for the things to be covered during the arbitration, that is the facial nerve and labyrinthal area,
Yes, yes, yes.
to prevent complications in the post-operative care.
Yes, sir. Yes, sir.
That's very important to know. So, you have given excellent input. I think it is very beneficial to the not juniors. It is meant for actually senior colleagues. This is talk.
Yes, sir. Thank you.
Really very happy. Prahlad.
Thank you so much.
So I wish to come to your institute.
You must. It's that is, our institute is waiting for your darshan for a long time. You have to put your right step inside sometime soon. Yeah.
Okay, brother. Okay.
Yeah.
All the best.
Yeah, it's been a wonderful covering all the aspects of mastoid cavity obliteration.
Thank you.
And particularly I appreciate the Karnataka flap.
Yes.
I really appreciate it's a very robust flap we have created, sufficient enough to fill all the cavity and giving a very good obliteration. And we can see actually the results at the end stage. The ear canal is looking almost like an ear normal, just wide ear canal
Yes,
line.
sir. Yes, sir.
And he can definitely get fitted with a hearing aid without problem. He can as well go for swimming also, I believe. It's an excellent technique to take, definitely. I think all the, yeah.
Dr. Kishore sir, there are some questions in the question box. You can open
Yes,
that.
I'm coming to that. Some,
Yes, pa. I'm here.
Before we go to the question, first I want to ask one question.
Yeah, yeah, yeah.
See, we are obliterating
Mm.
with the faith that it will take up and then it will not be any problem.
Yeah,
See,
yeah.
I have faced few problems in the post-operative period. Number one,
Yes.
the graft, the soft tissue, whatever is kept below the graft will get infected at sometimes.
Yes, yes.
And I had hell a lot of trouble with those patients for 6 months also. I need to take them to operation room many times and then debride all the necrotic tissue,
Yeah, yeah.
revise that. At this juncture, it looks very good if you have a very good result at the end of the surgery. But when you have a post-operative issue like this, it is very difficult to face the patient many times.
Yeah.
So now, what are the tips and tricks and what is the plan that you give us to avoid such
Yeah.
post-operative problems?
Yes, one is I told you absolute aseptic precaution is must, even though we are operating on an infected field. Okay, that is one thing we must ensure all the ENT surgeon this thing. And second thing, some flaps, they'll slough out in the initial period, and also there'll be some granulation formation. So that's why we have to call them back on a. We have to have a schedule like.
Can I request the people who are in this speaker group to mute themselves or not to make noise so that the program goes smoothly? Thank you.
Yeah.
Yeah, please go ahead.
Yeah. So what we have to do is, so we have to call the patient on scheduled dates. Like mine is that once we remove the pack on 15th day, that is 2 weeks of following the surgery, then I call them on 21 days. Till then, I advise them to apply some neosporin ointment inside the this thing cavity. Okay, underneath this, it usually heals well. That's what I've seen. And once I clean the ear thoroughly on the 21st day, I just give them, ciprofloxacin and dexamethasone drops. That usually takes care. And since we are using a pedicle flap and which is covered by, the temporalis fascia covers, only problem we face is the granulation tissue. Okay, that we just have to. I keep a curette and this thing, I use the suction tip to just scrape it off, and that's enough. And by end of 2 months, 2.5 months, a maximum 3 months, it will become a totally well healed cavity. Yeah. Cavity means extraordinary canal.
Question number two.
Yeah.
See, when you have to obliterate with the post-auricular, posteriorly based or inferiorly based flap, musculopenis flap, so you want that flap to be covered with the fascia, or there is no need to cover the fascia?
You have to cover that with fascia for good healing. If you just, the flap is there, the connective tissue, that will form a lot of this thing, granulation tissue. Even the temporalis fascia also forms a lot of granulation tissue because that's also connective tissue, but the amount is usually less. Amount of granulation forms is less. Yeah.
Prahlad, hello.
Yeah. Yes, sir. Yes, sir.
Prahlad, how about suppose if the small pockets are there, can you use the fat from the neighboring areas for obliteration? Free graft to.
Yeah, I think we can practically use it. We do that. We use the abdominal fat when we do subtotal petrosectomy and cul-de-sac closure. We use it. I think we can do it, but it needs an additional incision. See, you can get abundant flap either only the thigh or abdominal region. So I don't know whether the patient they accept that additional incision.
In those cases, in the fourth time, fifth time revision cases.
I think you can use it. You should be able to use it. You should be able to use it. Yeah.
See, when we do revision cases, especially in my experience, post-op, especially what is kept in the cavity and it is covered well also, it appears whitish as if it is necrotic
Yes.
for about 4 to 6 weeks time.
Yes, that's right.
So we need to be careful about that and wait clean, give antibiotics and then keep them calling. Whenever there is a necrotic, you can debride, but definitely at the end of 6 to 8 weeks time, they should heal.
That should heals. It usually heals. See, that is a normal healing mechanism. We should not hurry up thinking that.
Then you need to debride.
Yeah, no. What we do is we see that little bit whitish is there. We go and
Yes.
debride it. We shouldn't do that. Slowly it will heal. That normal healing mechanism, it has a course. It will take that course. It may takes about anywhere between 6 weeks to 3 months. It will heal. Nothing to worry about it.
Kishore sir, you can
There is one question from one of the participants.
Yeah.
Is Ram Shankar R. He is asking, what if there is recurrence after mastoid obliteration, and how to manage obliterated area and remove cholecystoma? That is recurrence after mastoid obliteration. You have a recurrence, and how to go with that? How to manage with the obliterated area,
Yeah.
and we are going to remove the cholecystoma.
Yeah, this is a challenge in these years. Okay, if there is recurrent cholecystoma, means we have not done a complete cholecystoma excision, and that is regrowing, or there's either is residual or recurrent disease that is there. So you have to go same approach. Go post-oral incision. You remove this now the obliterated whatever material you used, it has got integrated there into the local anatomy region. Okay, you go post-oral approach, elevate that like a flap, and complete again. You do the revision surgery, complete the surgery, and re-obliterate back like earlier. No problem at all.
We can re-obliterate again.
Yeah. You can re-obliterate, but ensure this time that no cholecystoma is left behind.
Prahlada, what is the role of MRI, contrast MRI?
Yeah, they
This
don't.
case.
They're doing it. That DWI MRI patient can afford.
Yeah.
You can go and. But if you only have a doubt, but
Yeah.
here there is no doubt. You see, if you're able to examine the ear and you see that their epithelial pulse are there, so that foul-smelling ear discharge is there, and you see the cholecystoma there, you just go ahead. Maximum you can do a CT scan, which is easily available everywhere. Yeah. Only such.
In your experience, you use only cartilage pieces, fibropathy tissue, free materials.
Yes.
This is better, or pedicle flap is better.
Pedicle flap anytime.
Okay.
Cartilage pieces, I use it mainly to get that contour, and I don't want to throw away these cartilages. And conchal bole for myotoplasty, you have removed the cartilage. Instead of throwing it out, better to use it to obliterate. Okay.
That's a very good idea, Rakan.
Yeah.
Sir, in the recent times, sir, there is a lot of people who are using bone pete actually.
Yeah.
Bone pete they are using. So, do you have any experience of using this bone pete?
I use bone pete also. If sometimes I collect and keep it. If I feel that not much cartilage, revision surgery, not much cartilage I'm going to get. Somebody has already used some cartilage for some kind of reconstruction. I collect the bone pete and use it, and that's also good enough. It forms solid bone.
It is just to dry drilling and collect the bone dust, or use any collecting device?
No, I don't have a collecting device. I tried to get it in India. Somehow it's not possible. I couldn't get it in India. That so what I do is in between drilling, what I do is I use the scoop, this or periosteal elevator, and
a lot of
That's what majority of the people do actually.
Yeah.
And do you actually instill it with any antibiotic solution or anything, this bone pete, or use it as it is?
Yeah. You can put it this ciprofloxacin and dexamethasone drops. Yeah.
I think the bone pete what you collect is from the surface bone is better than the one you go inside actually.
Yeah.
Jaya Prakash Reddy, once you get exposed the cells, mastoid cells, you have to stop collecting.
Yes.
Yeah.
Dr. Kishore is there. You want to add anything, sir?
Hello?
Okay, sir.
Okay. I think only I can, because I heard all the lectures and then Dr. Prahlada I can only congratulate that VP, AOI for arranging such a nice webinars. And definitely, as Appa said, it is not only useful for the juniors but also for the seniors to refresh and update our knowledge in the ENT field.
Sir, actually, sir, from AOI, we are spending only maybe 10, 15, 20, 30 minutes to arrange this program to speak with.
Yes.
But we have to congratulate the speaker for their valuable time of 1.5 hours. And
Yes.
some days of hard work, years of hard work,
Of course.
showing so many videos and beautiful pictures and narrations to understand the art and science of behind that. So that is very important. So that spending the blood and sweat to give us the, and it's not so easy to
Yes.
show this one.
Yes.
So that's the thank the speaker.
Yes. In the teaching field, because we are there in medical college road or service, to take that 1 hour lecture, we prepare 4 to 5 hours in the house.
True, sir.
Anyway, Prahlada has done a lot of work, and what I can say in a nutshell is he has done full justice to this mastered cavity obliteration webinar.
Absolutely.
So for this 1 hour, for 1.5 hour, we have done a lot of homework before this. Yes.
Yeah.
I should appreciate for that.
And I have one question, Dr. Prahlad.
Yes, sir.
Yes.
Sometimes we come across canal wall cholesterol.
Mhm.
Canal wall cholesterol, very wide in the canal. And maybe perhaps getting it into middle ear cavity, we need to do surgery for that. Do you do routinely canal wall down, this kind of cases, or do the obliteration of the canal, what kind of material?
Yeah. So coming to the extrinsic canal cholecystoma, I haven't seen so many, like some of the other senior surgeons, maybe about 6 or 7 cases, that's all, okay? But they were all limited to the floor of the extrinsic canal and limited posterior wall of the extrinsic canal erosion, but not going to the middle ear at all. So what I just did local drilling, okay, and grafting with the temporalis fascia and skin, that's all. I did not do canal wall down or anything for these cases. They're more of localized extrinsic canal cholecystoma
Yeah.
with minimal.
As Dr. Prahlad said, sir, we have seen many keratosis patients.
Yes.
And you can call it the external canal cholecystoma. In my experience, I have done maybe some hundreds of keratosis. I've seen only one young male who had second time keratosis, and that patient developed retraction and he may require surgery. This is the only patient I've seen. But I don't know whether many people are feeling that they've seen a lot of hundreds of patients. I've never seen such only a few patients I've seen.
Yeah.
And Dr. Prahlad, your points are very well taken, as we all know. Lowering of the facial ridge to the maximum extent and saucerization particularly to minimize the cavity. And what about the tip? Do you routinely take away the tip area, tip mastered in obliterations, or you can go away with that without tip excision?
No, I don't do, because see, most of the case we see is very well sclerosed, not extending to the tip, isn't it? Unless pediatric patients, extensive cholecystoma patients, tip is more or less, it's obliterated by the bone itself, the sclerosis of the mastoid bone. So it does not required at all. Only in cases where
pediatric cases,
pediatric cases, I take off the tip.
Yeah.
I let the sternocleidomastoid muscle, that attachment, kind of herniate into the mastoid cavity, so that also obliterates a bit.
That really helps in reducing the
Yes.
mastoid cavity. Yeah, that's good. Nice. So, with this, I think any more questions from any? I think online we have one more question. One more. Khuda Ali Basha. He was asking about mastered obliteration steps. Maybe he was asking this in the very early phase of your
Early
talk.
phases, yes.
And you have shown all the techniques very nicely.
Yeah.
We have the Karnataka flap and
Prahlad, there are a lot of viewers actually come from Abu Dhabi, Dubai. All these people, we have sent the messages to Malaysia also, some of our contacts.
Yes.
And this Raja has come, Raja Abdullah, they have come for our dissection courses. Lot of abroad people are there.
Yeah.
Who are asking,
Thank you so much.
say hi to you.
Yes, thank
Okay.
you. Okay. Yeah.
Apollo sir, you want to ask anything or we can call it for today?
He has covered the entire subject.
Yeah.
Still, I believe in, as Kishore was stressing upon the how to manage the tip of the mastoid in so cases to decrease the total volume of the cavity. I think it will be useful to remove the lateral lip of the
Hmm.
tip of the
Yeah.
mastoid.
But actually, the reason he decapitated the tip. They say. But actually, the revision patients may require.
Yeah.
Yeah, it reduces the height of the cavity.
Yes,
So
sir.
it comes to a low cavity space. So the lesser cavity space can be managed very well with obliteration.
Yes,
And
sir.
compared to that. In that angle, I think we can.
Yes, sir.
Thank you very much, Kishore, and for a good moderation.
Thank you. Thank you, Dr.
And
And as usual, JP is very active and vibrant.
Yes.
Incoming president.
Yes. Yes. Yes.
And Prahlad just made a wonderful presentation. This is not a new for him. Maybe he has given talks, and thousands, not hundreds.
Yes.
Yeah, he
Thank
was faculty in so many his own workshops and abroad and nationwide. Really, today we are gonna given a very good coverage of the mastoid obliteration. Prahlad, thank you so much.
Thank you very much, sir. I
Sahu,
think.
you
Yeah.
can say a vote of thanks and then close.
Yeah. My sincerest thanks to all of you, to the Sun Pharma and AP. Now with led by the incoming president and Apparavagar Saru, Krishna Kishore Sir Garu. My sincerest thanks to all of you for giving me this wonderful opportunity to say some of my work.
Prahlad, from APOA, our people actually should see your center, be there
Yes.
for some
Yes.
time
Yes.
to learn not surgery alone, how to publish a paper, actually
Yes,
how
yes.
to record so many things.
Yeah.
And I wish that too many people visit your place. Thank you very much, Prahlad, for your time. Amar, we can say a vote of thanks and we can call it for a day. Yeah.
So, good evening once again to all the respected delegates. Once again, Ahmad this side from Pharma Care Division of Sun Pharma. So, today's session was really very wonderful. I thank today's all eminent speaker, Dr. Prahlada N, sir, for a very impressive, very informative discussion, guidance, and for making this evening very enriching in the form of knowledge. As well as my heartfelt thanks to all delegates for attending today's webinar. On behalf of Sun Pharma, makers of September Montec Effect and Transport, I also thank Krishna Kishore sir and Jaya Prakash Reddy sir for navigating entire session wonderfully. And I am sure today's discussion will ultimately benefit several patients. Thank you for giving us an opportunity. As mentioned in the beginning, we have planned series of webinars. Today we have completed 34 series of webinars. We will soon come back with next schedule of webinars of the series. Thank you all. Thank you, sir.
Thank you.
Thank you.
Thank you. Thanks, Dr.
Thank you, sir. Thank you, sir.
Yeah.